God, quit trying to make shit up.
I thought we did. I got you ahead. No, I'm not, really. No. Probably go home, I'll come in sometime tomorrow and order like this.
Okay.
I thought we started at 18. Damn. I'm already ready to take food test. I mean, the practice test.
So, kind of a rundown of the next couple weeks, I guess. We're going to finish, we're going to work on 18 tonight. We will get a lab in for CPR. I just haven't sat down to schedule it. Oh, heck, by the way, we're live, so don't talk bad about anybody.
I really need to know when the class will be,
We don't know yet.
so I can know if I can go on a trip.
Well, when's your trip? See, you guys need to tell me with these things. That way I don't schedule
I'm
something.
just on the 6th of next month.
Okay.
Yeah, it's just a day.
But here's the deal. Yes, you can go. We aren't having class this weekend because it's Old Settlers. And we had 2 Saturdays in a row. Thing is, I think I accidentally scheduled class for my son's birthday. So I won't be here. We're having it the next Saturday. So we won't have class that next Saturday. I don't think we're scheduled to have class Saturday after that. Oh, we are? What's our next?
That's the Saturday I want to be on.
29th.
What?
The 29th is
Yes.
and I got a rodeo.
The 6th is the next class. So the 5th or 13th.
Okay. You can still go on your trip, but we'll have class. Just watch. I won't do a lab that day. Okay.
So then you're gonna take this out or whatever.
Oh, well, I didn't. So I didn't have.
Yeah, you need it.
Oh, I did. Okay. Yes, we will not have class on the 29th, but we will have it on the 6th. The 6th. And I don't think we'll have it on the 20th. So, or the 13th, but maybe the 27th if you guys are willing to move the 20th for the 27th. And so there'll be a 6th and 27th of May will be the next Saturday classes. Will that work?
You mean classes or labs, Rob?
Just classes right now. I'm not exactly. I haven't looked at the lab schedule. What I need to do is sit down and actually look at the labs and try to schedule them out. And it might just get to where we get through a lot of these chapters, and whenever we have a Saturday that everybody's going to be able to be here, we just have a big lab day. The reason is it's just there's so many things coming up. I haven't had a chance to look at it yet because I'm trying to do my EMS service license renewal, which they've added a whole bunch of things to it, so it's made it a big headache. And so I'm kind of dropping the ball a little bit, but I'll try to get that looked at maybe tomorrow or the next day. I'll try to make it a priority. And then that way we kind of have an idea of what's going on. Like I said, if you are going to, let's do this. If you guys are going to be gone over the next 3 or 4 weeks, give me the dates you're going to be gone, so make sure I don't put a lab on that day. That would help out a lot. So, no 20th of May. 6th and 27th are the only days we'll have in May. And we may not even have the 27th. But my wife has me doing so many things. So we gotta start getting focused on finishing some.
I'm gonna ask like on the 25th of this month, it is next Tuesday. Is our CPR.
You have next Tuesday as our CPR? Okay. That might work.
Is that a lab?
Yeah, that would be a lab. Sure, 25th. Aaron, Emilio, and Rebecca, are you guys able to do the 25th for a CPR lab? It's a Tuesday?
Yes, I can do it.
Okay.
Yes, I can be there.
No, that's fine for me.
Sounds good. What's that, Aaron? I'm sorry.
that day should work for me.
It will work for you, yes?
Yeah.
It's, okay.
As far as I know, if they don't call me in the morning, I'll be there.
Okay. Either my connection's slow or we got a little, yeah, it sounds like a robot voice, so sorry about that. Emilio, how about you?
Yeah, I can do Tuesday.
Okay. Let's just plan on the 25th doing the CPR class. That will help kind of alleviate some of this stress. So we're starting on 18 tonight, which is cardiac, right? So where were all you students at today? Gee, you have a radio, right? Right?
I don't take it to work with me.
Well, you wouldn't have been able to get here in time anyway. So
Hey, Rob, I have to go to work, so can I just watch this on YouTube when we get done?
sure.
What?
Yeah.
I can't hear you.
Yeah, that's fine. I'll kick you off. You get out of my.
Okay, thanks, bye.
Bye. I've always wanted to eject somebody from the hangout. Yeah. I know we didn't do anything, but we did something today.
I know. We're getting something.
Well, it's probably
At the hospital already.
probably the same. I mean, yeah, it was just yeah. Whenever they're down for
Today too? Today and yesterday?
yep.
So who's gonna be the third one?
Well, we've already had a third one. It was on Saturday.
Oh, wasn't it Saturday? I didn't get one.
Or did you get on the Saturday one? No.
I don't know, because they can't talk about.
I'm trying to stall a little bit because I sent somebody after some food for me because I ran a we left for a code at 4 and so I just got back from running the code and I'm hungry. Yeah, get it out of the way.
Get it out of the way.
What you need is a smashed up person, like somebody that just like.
You can do all kinds of things too, and then that.
Well, no, they're already dead. You just need to see. You need to see the extreme gore, and then either throw up and go home and cry and say you don't want to do it,
Yeah.
or throw up and go home and say, yeah, it's all right.
That would be the way to do it. I mean, don't waste my time with the rest of this.
That's kind of like the tennis series I watched today. I'm like, really? Tennis thing?
No, I'm not gonna say I have a harder time. I don't really have a hard time with it. To me, the smashed up, mangled, burn up, whatever. Yeah, it's all whatever. As long as I don't have to touch it, I'm good. What I hate doing is not hate doing, but it's a hard thing to do. Is having to tell family members, sorry, there's nothing we can do, and we're not going to take them anymore. We're leaving right here on the floor. And I guess it's the human side of it. It's yeah, so yeah, I hate doing that, but it's something you have to do. Some people won't do it. Some people transport but I won't. I'm not gonna transport a guy who's been down for over 20 minutes and by saying there's CPR and he's in facility when you get there. Fix the dilated pupils. I mean, there's nothing that can be done for him. And then have to tell the family everyone, I'm sorry, but that's the hard side for me. It's not the smushed up people, unless somebody's standing on the side of the road whenever. So I'll tell a little story while we're waiting on Serena. I don't really have many of them that stick with me all that much. There's a few of them. The one of them was that we had a head-on car crash. It was a drunk driver incident. The person in the passenger seat of the drunk driver car was dead. And there's a little group of people kind of, this is in Wichita, kind of like back around the back side of the wreck, and then the other car, the people hurt really bad. There's a lady, her whole femur was open, and she was in a lot of pain. There were 2 passengers in her car. There was a driver who was injured. There was a person or 2 in the back seat, and so the firefighters pulled this guy out of the passenger seat. So we have 1 ambulance and 1 fire unit, and we have several patients. And they pull him out and start doing CPR. And So you walk, and this, you guys heard me talk about the guy, his head that's on Chris, but this is the guy. And so I walk over and I look down, and this guy's freaking head is on crooked. He has an obvious broken neck, and I said, "What are you guys doing? Stop! He's dead. Leave him there. Move on." And then I hear in the background a scream. Well, come to find out, this was this dude's girlfriend that was in the car too, who was pregnant with his baby. You know, and so that was that you know, that kind of stuck with me. That scream, that human side. But you know, I felt like that car. I always have a hard time feeling sorry for people who I feel like caused something. So this was a car full of drunks that were this guy, you know, was pulled out of. I'm glad that the dead person wasn't in the other car because they weren't a car full of drunks. And you know, it's just that you don't, you know, in life you don't see a lot of what, you know, you call justice, and it's a sick way of justice. But it's, to me, whenever the people who are being an asshole are the ones that are, you know, get killed, I feel a sense of relief. Okay, God, they're the asshole guy. You know, that's terrible.
Oh, how scary! Because then I'm like, road rage out, pacing, he's looking him down, and then I'm thinking, calm down, because you can have an accident.
I should clarify. I'm not happy that the person died. I'm happy that if somebody were to die, it was the one that was being, you know, doing the wrong. Thank you. Well, I'll go ahead and open up these slides, and we'll kind of get started slowly until Serena gets back. I feel guilty for starting without her since I sent her for some food for me. But let me. Oh yeah. Uh-oh.
89.83 or something.
You dropped below the 90?
Yes.
Oh, man.
Like an 85.
You better get with it. An 85?
85 okay.
Yeah, I told her I wanted a Reuben sandwich with cheese fries. That's probably going to take forever. I got to stop eating like this. I got to. Oh, you overachiever.
I just dropped mine down to 89.83 or something.
So, cardiac emergencies, chapter 18. Cardiac, you run some cardiac emergencies, but whenever we're talking about cardiac emergencies, we're talking more than just cardiac arrest. We're talking about chest pain or cardiac-related signs and symptoms. Hey, ventricular fibrillation video. That's slide 102. I think I'll wait for it. Yay! I'm surprised they didn't arrest you. Ask you what you're doing stealing people's cars.
Chrissy better kind of heavy.
Thank you. Did you give her?
Oh,
She got a wheel and now make a credit card.
there'll be a time.
Guess who
Weird.
Guess who used Rob's credit card?
Guess who came and used his credit card? Are they having an affair?
That'd be terrible.
Because then you don't have all the way in between beating up.
Okay.
I've been beat up.
That's how innocent things get turned into craziness.
Yeah,
Mhm.
you just announced it live to everybody.
All right. I owed her because I ate all her wickles or whatever them things were the other day. I felt bad because they were like her meal, and I'm like, I devoured them all.
And then she looked at him like,
I know, and she's like, "That's all right. I don't eat that much anyway." And I'm like, "Oh shit, I feel terrible."
my kids still want food anyway, so.
She's like, "I better buy her some food. I better pay her back." Cardiac anatomy and physiology. So, Review the cardiovascular system. Now, flow of blood through the chambers of the heart. Did you guys kind of study that whenever you did it? Cardiac conductive system, composition of blood, flow of blood through the arteries, veins, arterioles, venules, and capillaries. I'm thinking they're going to get just a little more in depth than they did in the other ones. Ellen, you want to teach while I eat?
I can read the slides.
That's all I'm doing.
That's all I'm doing.
Yes.
Circulation of blood between heart and lungs and between heart and the rest of the body. Do we really need to review all these? I felt like we did a pretty good job going in depth.
Yeah.
We'll try to just kind of go through them. How heart functions and circulation of blood relate to pulse and blood pressure, and then shock hypoperfusion. We'll see if there's anything new with date. There's a heart. Yay! We've seen this picture before, right? Here's kind of the flow of the blood. That's a fairly decent picture if you read it. But if you draw it on out to like go to the lungs and things like that, to me, the visualization becomes easier to see it. Because without going, okay, too long, read it. That's one thing, but
It's not in the,
Yeah, I already looked at it.
it's in the other one.
No.
yeah, I know. I don't know. They're making us review it, I guess. So moving on. Think about it. How does the normal function of the heart and blood vessel relate to blood pressure and visceral pulse? How shock relates to the function of the heart and blood vessel? We already talked about these things. We haven't talked about acute coronary syndrome, though, have we?
We are there.
Acute coronary syndrome, sometimes called cardiac compromise, refers to any time the heart may not be getting enough oxygen. Many different kinds of problems under the ACS heading. ACS is a fairly new term or whatever. Whenever I was going through EMT and paramedic school, we didn't have ACS, but now they have ACS algorithms, and ACS stands for acute coronary syndrome. And it's a good way to lump everything that's not chest pain and even chest pain under one umbrella. So before they would just say things like, "Oh, this is a sign and symptom of a possible heart attack." Now they say, "Well, this is acute coronary syndrome." Well, symptoms often mimic non-cardiac conditions. Treat all patients with ACS-like signs and symptoms as though they are having heart problems. Chest pain is best known symptom and can be described as crushing, dull, heavy, or squeezing. Don't be fooled. Every once in a while, I'll get somebody that describes it as sharp, and I'm like, kind of, and then it turns out to be an actual cardiac event. It's so don't rule it out just because they say sharp. But usually, if it's a sharp chest pain, it's not cardiac related. Yeah. Sometimes described only as pressure or discomfort. Radiates along arms down to upper abdomen or at the jaw. Also kind of into the back. This dyspnea, also found in ACS, may be the only finding in some patients. I just can't catch my breath today. I don't know what it is. This patient that we ran today hasn't been able to catch his breath for a couple days. His was probably more of a respiratory tract infection, went hypoxic, and just kind of went down that whole spiraling cascade into cardiac arrest. But he could have been having an acute coronary syndrome. Other symptoms: anxiety, feeling of impending doom, nausea and pain or discomfort in upper abdomen, epigastric pain, sudden onset of sweating, abnormal pulse, tachycardia or bradycardia, and abnormal pulse pressure. So you get that 110/90. Now you get or I think you could also get the further out, so like 120/40. The sudden onset of sweating. This is sitting there in their chair, have a sudden onset of also they're watching TV. And all of a sudden they become very diaphoretic. And they don't have an explanation why. We talked about all these things. I don't know if we've talked about the impending doom thing. That is a sign you want to listen to. It just doesn't feel right. I don't feel good. I feel like I'm going to die. No, don't say that. Bad.
Don't say that. Be ready.
Mm-hmm. Patient assessment. So you want to perform your primary assessment, obtain history and physical exam, use OPKRST to get history of present illness, obtain past medical history, and take baseline vital signs. Patient care, place patient in position of comfort, typically sitting up. Determine if oxygen should be administered in transport. I'm not one for putting high flow O2 on everybody, but if you have somebody that you think is having the ACS, I'd at least put them on 2 or 4 liters by non-rebreather mask, or nasal cannula. Not non-rebreather mask, no! By nasal
Maybe I
cannula.
need a non-rebreather mask.
If they need oxygen, let's say that you get that below 94%, definitely do non-rebreather mask.
So you're talking about if they're not below 90?
Yeah, if they're not below 94, let's say that you run something 96, 98%, but you think they might be having a cardiac event, I would definitely go ahead and supplement with 2 to 4 liters by nasal. Those are about the only patients, them and patients that give opiates too, are the only patients that I really ever put on oxygen. Or by nasal cannula. That's the only ones I use nasal cannula for. Patient care, if trained, equipped, and authorized to do so, obtain 12 lead electrocardio ECG. 12 lead, we call it EKG, electrocardiogram. The old, I guess that's German. But they also see it as ECG a lot. Roger Mills County does have 12 lead EKGs that basics could put on. The monitor interprets the rhythm, but also used to. I think I probably need to see about this the other day. Zoll actually shut down the way that we did it. I have to set something else up to do it. But we were able to transmit the 12 EKGs to the hospitals, to their fax machines. And they would also go to my cell phone and to the whichever physician. They could go to Dr. Eubanks or our medical director's cell phone. So, follow local protocol as to whether to transmit it to the hospital for interpretation. I think you're going to slowly see that more and more. Indications for administering nitroglycerin, chest pain, history of cardiac problems, and prescribed nitroglycerin. Physician has prescribed nitroglycerin to patient. Patient has nitroglycerin with him. You see the common factor there? You have to administer them their own nitroglycerin. All right.
I probably had nitroglycerin on a thing.
We do, but as an EMT basic, you're in Oklahoma anyway. You can assist with theirs. You cannot use it off the ambulance. I'm not sure if advanced can. I'd have to go look at their protocols, but paramedics use nitroglycerin. It's nitrostat. It's a pill, goes under the tongue. So patient care indications for administering nitroglycerin. Systolic blood pressure meets protocol criteria. Typically above 100 systolic. Patient has not had Viagra or similar drug for erectile dysfunction within 48 to 72 hours. Medical direction authorized administration of medication. That one would depend on your state and your local protocol, whether medical direction is required. I believe in Oklahoma, if they have it prescribed to them, you don't have to get an order.
Would that not be like we could get orders to use off the ambulance?
I think you're going outside your scope of practice at that point in time.
Okay.
What I will say, and I wouldn't document it this way, I'd be very creative on the documentation, is if they have nitro but they don't have it with them and you use it off the truck. You get where I'm going?
Yeah.
Patient care, after giving a dose of nitroglycerin, repeat dose in 5 minutes if patient experiences no relief or only partial relief. Systolic blood pressure remains greater than 90 to 100 systolic. And that 90 to 100 systolic is kind of state protocol dependent. Some protocols I've seen say 90, some protocols say 100. Medical direction authorizes another dose of medication. If you do have to call in for an order, you're going to give them their medication. I would go ahead and call in and ask for order of sublingual nitro, Q5 minutes as needed for pain times to a max of 3. That way, or you could say to the doctor, I'd like to give nitro sublingual every 5 minutes if they're still having pain to a maximum of 3 doses. Get that order so you don't have to call back and bug them every time you want to give a nitro. So. Indications for administering aspirin: chest pain, patient not allergic to aspirin, no history of asthma, and then patient not taking medications to prevent clotting.
I haven't found any medications that I'm allergic to.
I forget the reasoning with the aspirin and asthma. I think it's more of children. But what's that?
They get, what is that,
Well, the,
I was just gonna say that, there's a reason you don't give aspirin to children, is because rise,
Wolf Parkinson White syndrome.
rise or something like that. I don't see no person that can make it. These are children's hospitals.
Indications for administering aspirin: no other contraindication to aspirin, ability to safely swallow, and medical direction authorization. You don't have to get authorization here in Oklahoma. I wish that they would say, per protocol, because on your national registry test, you're not going to get protocol type questions. You're not going to have to know whether you call in for medical direction or not, because every service, every state is different in the protocol. You will have to know when and why you give aspirin and when you shouldn't give aspirin or other medications. There's some Gold Line chewable aspirin. Causes of cardiac conditions. I'm a mess of myself over here. Heart problems caused by a number of disorders affecting condition and function of blood vessels and heart. Conditions that narrow or block arteries of heart often result from fatty deposit buildup of inner wall of arteries from eating cheese fries and rooted sandwiches. Buildup narrows inner vessels diameter, restricting blood flow. I can feel this happening now as we speak. Thrombus, the occlusion of blood flow caused by formation of a clot on rough inner surface of diseased artery can break loose from. What's up?
Building bikes now.
Oh, I'm rebuilding carburetors. Man, you still look like shit.
Yeah, I feel better than I did last night.
You got in a fight.
Shit, liar.
Got stung by a bee. Man,
How was your call?
man. Dead?
We need to skip to chapter 20, that's what he said.
Emboli can move to occlude flow of blood downstream in a smaller artery. See if they say something. Reduced blood supply to myocardium causes emergency majority of cardiac-related medical emergencies. Chest pain is the most common symptom of reduced blood supply. Let's take a break. Let me finish eating, and we'll take a little break. Take 10 minutes so I can finish eating this. I'm not trying to talk and eat at the same time.
I started checking that patient over at Hammond.
And then they take
Uh,
aspirin to treat
we got there, and I mean, he was done 20 minutes or more before we got there. She had done decent CPR, but he didn't pay Cicely when we got there. We had 3 rounds of epi.
Okay.
Went into a PEA, but
I got smoke.
I've been with you enough, I guess so.
epi wore off and
Did the
went
pee?
back to Cicely. I mean, there was no pulse, no heart pains, fixed dilated pupils.
Get out on the
We called it.
out there.
How do you call it? You got a call.
We called Elk City because that's where she would have transported to, and talked about the project.
So then what do? You still got a haul down,
You leave them there.
leave there, let Emmy come get them.
Mm-hmm. Yeah, as a matter of fact, that's kind of what American Heart is recommending now, rather than wasting money and resources on patients that aren't going to make it. Going ahead and calling it we want to team. But yeah, we called it and came home.
I was looking at my pals and my, what's the other one? How the ACLS go out this year.
No, they don't, because you got a packet over there to renew them.
Oh, do I really?
Do you not read your emails from me?
Well, I read your email, but you weren't here, so I could do all my paperwork.
Yeah, we'll get them. That's PALS, ACLS, BLS, BLS instructor, PALS instructor, and ACLS instructor.
Where's it at up there?
Your name, it'll be a packet with your name on it.
Okay.
Take the rosters, make sure that you sign every roster. The date of the class will be on that roster. So, and make sure you fill out whenever you do PALS paperwork, you do the PALS roster and blah, 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 put the right date.
Okay.
And then you'll have a folder over there with your name on it, with all the stuff you need in it. I'm gonna take this in here and get some crunching by the microphone.
Hi, honey.
She told me she's not talking to you.
Huh?
She said she's not talking to you today.
Hey, I tried to do the, medicine report right now.
Yeah.
And my time card. I can't even get into the time card on Drive there. Really? On the control panel. It'll go in, I go into it, but it won't give me the link. Probably something wrong with my phone, but.
Weird. I'll look at it tomorrow.
Okay. But I looked at the drugs, it seemed all there. Without the checklist, I'm not 100%, but.
still the beef honey when they're talking?
Say what?
Were you still the beef honey when they're talking?
No, I was actually feeding them. I had half a dozen the day before and didn't swell up at all. I think it's just where they got me.
All right, I'm ready to rock and roll now.
Hey, what about this right here?
Don't worry about it. The start date will be the day that class is, but don't worry about it.
Okay, what was the date?
It's on the roster for that one.
Haven't seen the roster for that one though.
Well, you know, your rosters over here.
Oh,
So ahead of them. Your BLS roster,
I got you now.
your BLS course instructor.
I'll just need that whole staff. Shit.
Don't mix them up.
I'll do it on purpose now.
Shuffle.
Was having class out there. Was looking at my ambulance.
How many minutes has it been? Have been 10 yet?
Uh-huh.
Well, I'll start class out.
This girl's terrified of injections.
Dog. Come here. Sit. Good dog. Good dog. You better shed your winter coat pretty soon. It's pretty fluffy. You're gonna get hot.
We're out doing the
Ron
last.
has chains. He wraps the chains so we are safe.
Do what? All right, aneurysm.
Who's waiting on us? Waiting on us?
We were observing. the
We're observing
ambulance.
the ambulance.
She's never seen the back of an ambulance.
Yeah.
She's seen it.
First time I ever been in one.
Yeah.
Yeah, I don't make a habit of getting in them.
Yeah. I don't. I mean, either.
I mean, just saying.
Then I gotta do paperwork. So, weakened section of arterial wall. So the aneurysm's weakened section of arterial walls begin to dilate or balloon. Bursting can cause rapid, life-threatening internal bleeding. If it's talked about in your assessment of the abdomen, if you feel that pulsating mass or complaining of a sharp pain in their stomach or into their abdomen, and then want to go to the bathroom before you go, don't let them do it. All right. So a lot of times an aneurysm, whenever they're complaining of aneurysm, they'll complain of a sharp stabbing pain. Can be in their chest. Could be the aortic arch or something like that. Has a small aneurysm in it. Could be in their abdomen. They could have aneurysms in their head. So about anywhere. Oh, that's a picture of one bursting. There's aneurysm. You see the you see the balloon, and then you see it burst, and then it's a life-threatening bleed. So electrical malfunction of the heart, malfunctions of the heart's electrical system generally result in dysrhythmia. Dysrhythmias include bradycardia, tachycardia, and rhythms that may be present when there is no pulse. The patient that we had today, I don't know if you heard me talking to Tyler, we went there with asystole, we did some CPR, we gave him epinephrine, we had what looked like a pulse back on the monitor, but when we checked for pulse, there was no pulse, no heart tone. It's called a PEA, or pulseless electrical activity. And so basically what's going on is the electrical system of the heart's working, but the conduction or the beating part of it's not. The muscles aren't contracting. Other dysrhythmias, such as bradycardia, no longer are you having the impulse come from the SA node where it needs to. It comes on. It comes from a lower place. Which has a lower intrinsic firing rate. And so Depending on what's going on with the heart, you could have different types of dysrhythmia. Whenever you go on, if you go on to do something like, do you guys read many EKGs, or do you guys just?
If it's interesting, really take them apart.
Yeah, and that's what we do too. You start missing a P wave. You kind of try to figure out, is this a idioventricular type rhythm? So is it coming from a different part in the heart? Usually from the bundle of His or Purkinje fibers. And then, obviously, if you're B-Fib, B-Tac, it's just kind of firing all over. So mechanical malfunction of the heart, angina pectoris, acute myocardial infarction, and then congestive heart failure. So congestive heart failure is typically caused from an AMI or acute myocardial infarction, where a part of the heart is damaged. So now it's not able to beat as strong. It doesn't have that contracting force. And so then you have the backing up of the fluid. So, angina pectoris, chest pain caused by insufficient blood flow to the myocardium, typically due to narrowed arteries secondary to coronary artery disease. Pain usually during times of increased myocardial oxygen demand, such as exertion or stress. So a lot of times they'll go ahead and do a stress test on them to see, kind of different things, but they'll do stress tests on them, see if they can reproduce that if they don't see anything in the labs or whatever. So moving on. AMI, death of a portion of myocardium due to lack of oxygen. Coronary artery disease is usually the underlying reason. It just kind of blocks off or occludes to a point where it completely occludes the blood flow, and they start having chest pain. You can see it in the EKG. Typically, younger people, whenever they have AMIs, and if they go to cardiac arrest from it, it's harder to get them back. Older people have developed collateral circulation. The plaque is kind of built up at a slower rate, and so then the heart creates these vessels that go around it. And typically, these older patients are actually easier to get back than the younger patients. It's kind of opposite of what you would think. There's kind of just a picture of what it would kind of represent. So you see that it looks like a little area there, but then you dissect out the heart, and you see that it's a large area of muscle that's affected. And we would be able to see all of that just by how the electrical system works. On the heart, we are able to go and look at the different leads, depending on where we see the elevation, will tell us where this myocardial infarction happens. At the basic level, your monitor will just say acute MI suspected. It really won't tell you where. So, congestive heart failure, inadequate pumping of the heart, often leads to excessive fluid buildup in lungs and or body. May be brought on by diseased heart valves, hypertension, obstructive pulmonary disease, often a complication of an acute myocardial infarction. So, I think my wife is messaging me again. So, like I said, you guys are at the basic level. For the first time, starting about 5-6 years ago, for the first time, you guys had just as good of a weapon for treating CHF as we did, which is CPAP. It is the best field treatment for CHF. So we don't even, like in the protocols and stuff, we don't even carry Lasix anymore on ambulances. They found that the Lasix is a drug that typically is used to treat congestive heart failure. It pulls the fluid off. But what they found is that, especially in the field, we're give them like 40 to 80 milligrams of Lasix, 1 milligram per kilogram. And we're pulling this fluid off these patients that are probably already dehydrated. And so we're killing them. And so they found that. So you've seen a change in the treatment. You started seeing doctors and even paramedics running fluid when they give the Lasix, but let's just make it all simple. Get rid of the LASIK off the truck and do CPAP. And I've seen CPAP take a patient from not talking in complete sentences, struggling, to talking in complete sentences, and a complete turnaround in their whole demeanor. From that, they look sick, they look like they're going to die, to smiling, kind of waving as they're going out of the hospital onto the aircraft. And so it was a huge. It left a huge impression on me. You know, I'd heard all the analogies of, you know, CPAP is to CHF as dextrose is to insulin shock. But until I actually seen it, I didn't understand just how fast and how well it worked. So, congestive heart failure progression. Patient sustains an AMI, myocardium of left ventricle, dies because of damage to left ventricle. Blood backs up into pulmonary circulation and lungs. If untreated, left heart failure commonly causes right heart failure. So now you had it backed up in the lungs. We didn't treat it. Now it's backing up into the body. And now you have this pitting edema and wet lungs. So yikes. Congestive heart failure symptoms is tachycardia, shortness of breath or dyspnea, cyanosis, or they kind of have that blue tinge around their lips, normal or elevated blood pressure. Typically, by the time they call us, it's an elevated blood pressure situation. And whenever we're talking elevated, we're not talking like 220 over 120 or anything like that. Sometimes it's 160, 180 over 90 to 110. It's still elevated, but it's not crazy high. So diaphoresis and then pulmonary edema, or what you'll hear is wet breath sounds. Typically, you'll have a history of CHF whenever you have that. But remember, you could have that AMI. They sound wet in the lungs. They're having chest pain. Maybe they had a heart attack, and now they're having congestive heart failure. Signs and symptoms: anxiety or confusion due to hypoxia. Basically, the lungs fill up with fluid, and so now that exchange of oxygen is not able to happen. They're not able to take oxygen in. They're not able to get rid of waste. Pulmonary edema, which is swelling, pedal edema, which is swelling in the feet. And they call it a pitting edema. It could be up into their shins and everything. And whenever you push on it, it's swollen. Whenever you push on it, it stays. And that will be your pedal pitting edema. And nurses and doctors, and I don't exactly know how the scale works, but they'll rate that from a plus one all the way up. And I don't even exactly know how that scale works.
It's like, oh, I got that.
That is disgusting. Sometimes they get so full of fluid and stuff that they start to weep. That gets pretty nasty. Yeah. Yep. You have so much extra fluid that your skin is taut and it's weeping.
You take a blood pressure, and it just squeezes that fluid out of it.
And then it just stays. It's weird.
Yeah.
I had a guy that hung himself one time with a belt. Speaking of things that stay, and he'd been there for a few days and bloated all the way up to that belt, so it looked like he had a shrunken head. The weirdest thing ever. So. Just saying, that's pretty weird.
Hungry yet?
Was that here?
No, that was in Wichita.
I just wondered who picked up the guy that hung himself on our gate out there.
Oh, somebody hung themselves on your gate?
So one of our pastors.
That takes dedication. Oh, you mean, but it was a.
Over on the overhead, yeah.
Oh.
He popped his drug test, so he killed himself.
Well, that's stupid.
Instead of going home to his wife.
Yeah, instead of going home to his wife, tell her he popped his drug test, he killed himself.
Well, now she knows. I mean, duh. And you're dead, stupid. So, engorged, pulsating neck veins. This is a late sign, guys. If you see this, yikes. Enlarged liver and spleen with abdominal distension is another late sign. I'm hoping that we're getting called way before this. Hopefully, this is something that the hospital sees. Heck, they should. I guess we're going to see it because they're going to wait that long. But cardiac arrest. Pretty self-explanatory, right? Heart stops. 5 elements. Chain of survival. This is the HA chain of survival. I've been an HA instructor forever and ever and ever, and I cannot tell you the chain of survival. I'm terrible. I always skip over it. I think it's lame. Because it has things like immediate recognition and activation. Yeah, okay. Early CPR, rapid defibrillation. So over 20 plus minutes for the ambulance to get there is not rapid defibrillation. Effective advanced life support, integrated post-cardiac arrest care, teamwork, and coordination. Out here, typically your codes don't go real smooth. We don't run a lot of them. Don't get a lot of practice. I'm even rusty whenever I run a code, and so a lot of coordination goes out the door. I know what they mean by coordination, like you do this, you do that, and everything. But it gets kind of. I felt like the one today went fairly well. We had Sabrina on scene, and Sabrina has run. She is involved with many codes, Elk City ER nurse, and flies with Larry back. So, but the guy was. What's that?
It just says they kill many people.
Yeah, there you go.
Only 1 in 5 survive.
So requires prompt notification of EMS system, most likely a bystander responsibility. It's your responsibility to notify EMS. Early CPR increases survival chances significantly. 3-way CPR can be delivered earlier. Get CPR trained professionals to patients faster. Train lay people in CPR and train dispatchers to instruct callers how to perform CPR. They actually had that today. So we had bystander CPR, and she's actually doing a very good job. I was fairly impressed. It doesn't eliminate the fact the guy's been without a pulse for over 20 minutes. So one thing I do like about AHA is they have simplified the whole CPR process to the point of whenever I teach a class, and if I forget to tell you, I'm telling you now, if the first time you go to do compressions and all the numbers, you cloud up and you can't remember all those numbers, if you can remember pushing the center of their chest and press hard and fast, you're doing something for the patient, okay? And so AHA has really gone towards that push hard and fast because they understand, it's been a year since you had your CPR class, you're not gonna remember the numbers. They don't want you to freeze up and not help this person out because you can't remember the numbers. And I used to, when working in Wichita, used to come across people that CPR certified all the time that are sitting there looking at a dead person because 1, they couldn't remember the numbers. 2, they didn't want to do mouth to mouth. And that's another thing. For the layperson or a heart saver side of it, and even healthcare provider by themselves, if you don't have a barrier device, you don't have to do mouth to mouth. You could do compression only CPR. When we get there, we're going to use a bag valve mask, intubate, or drop a king airway anyway, which we did both today. I didn't like the tube. I'm fairly certain it was in, but I ended up pulling it because we couldn't get good breath sounds. I think he just was so full of a real thick white mucus came up into the tube. I think he's just so full of pneumonia or something. It was bad. So I said, I don't like this, and I pulled it. But I watched it pass through the cord. We had right side breath sound, so I think that's a little deep. I pulled back. I never could get right side of breath sound. And I could never get that mucusy gunk coming up. And it wasn't like whenever you get to the stomach, that's a different thing. That is liquid and comes shooting out, and it's disgusting. You can't stop it.
Or beer.
Yeah.
That beer spout that day.
Oh.
It was pure beer, and it was spewing out of the EP tube, and I was like,
And I was like,
look at this, it's beer.
cake party.
I was just like, son of a gun. There's a pure stuff coming back.
Yes, put it in my mouth here and do some kind of vomited food.
It wasn't beer. It looked just like beer.
It was beer. It wasn't vomit. It's a cake party.
It's a vomit.
Get your cup, fill it up.
Absolutely nothing but beer.
So
You don't believe?
Vomit and puke.
No, it
Poop
wasn't
and puke, I
vomit.
don't handle very
It
well.
wasn't vomit, it was beer. This is like,
So I like the direction AHA's going with simplification at all levels. ACLS is no longer a big scary class like it used to be whenever I first did it. It's a friendlier, do BLS stuff, and then if you get time, do advanced cardiac classical type situation. But I do like the fact they've been making it a lot easier and a lot less scary. Hey, do something for them.
They pulled the suit out, you know, re-put it back in, or save the patient.
Oh, the beer guy?
Yeah.
Did he have beer aspiration pneumonia?
Well, he didn't.
So high performance CPR. Changes implemented in resuscitation efforts. Guys, there's changes that happen on AHA every 5 years. You have a guideline change every 5 years. They need to sell textbooks. Yeah, the biggest change in AHA history was when they went from ABC to CAB just not too long ago. Compressing the chest. Well, whenever I first got into it, we were so worried about the airway. Compressions were kind of a side thought. Now it's compressions, and airways a side thought. Compressing the chest at least 2 inches in adults, and not any more than 2.4 inches. Allowing for full relaxation on the upstroke of compression. So you want to take your weight completely off the patient's chest so the blood can fill back up with, or the heart can fill back up with blood, and then you squish it around again. Spinning half of each compression on the downstroke and half on the upstroke. I'm guessing what they're saying there is a very fluid, rhythmic compression. Using correct hand position. Compressing the chest at least 100 times a minute, no more than 120 compressions a minute. After 120 compressions a minute, you're not allowing the chest to fully recoil. You're not letting that heart fill back up with blood. And so you're just kind of defeating the whole purpose of doing the compression. Spending no more than 1 second on each ventilation. And then minimizing interruptions of CPR to no more than 10 seconds each. High performance CPR key is increasing cardiac output. Since most cardiac arrests in adults are the result of cardiac problems, not respiratory problems, there is enough oxygen in the bloodstream to maintain metabolic process for several minutes. I really think my guy's problem was an airway issue. He's already on oxygen for emphysema. The people in the house were sick, and whenever I went to intubate him, his sick came out of his up into his ET tube. It was pretty nasty. I suctioned ET tube. I actually just took the yonker and shoved it down in the tube and covered it. Yep. I couldn't find a soft catheter, so I like sucked all that stuff out. The sooner defibrillator arrives, the more likely the patient will survive cardiac arrest. The statistics that I last seen was at 4 minutes. If it takes more than 4 minutes, their chance of survival decreases by 75%, and then it's an additional like 25% every minute after that. So I'm not talking 75%, now 100%. It's 25% of what's left. 25% of, so you eat up that time fairly quickly, or that chance of survival fairly quickly. So you have if you had 100% chance and 75% chance at 4 minutes, now you only have 25% chance. Now it's 25% of that. You lose 25% of that. 25%. You guys get it? Great. Percentages are awesome. So, 25 times 25. What is that? So you're going to take off. Never mind. So rapid defibrillation. Don't push the green button. Press the red flashing button. The green button is just to power it on. So whenever you are going to use an AD, the first step of the AD is to power it on. The AD will start talking to you and tell you what it wants you to do. Generally provided by EMT paramedics. So effective life support generally provided by EMT paramedics who respond to a scene or rendezvous with BLS unit and route to hospital. Rapid transport to hospital may be the most time-efficient means of obtaining ALS. Unless you have ALS on your unit, then yay. So we have ALS tonight. We had it today too. You need a good coat, Tyler.
Okay.
And one with lots of vomit.
God. Poop and puke are two things I don't deal well with.
What's that?
Poop and puke.
Rotten humans. I don't like. I don't deal with rotten humans.
Yeah. Some of them are still walking.
I don't think he is anymore. So, coordinating numerous means of assessment and integrated post-cardiac arrest care. Coordinating numerous means of assessment and interventions that together maximize the chance of neurologically intact survival. Guys, that's key. So we get a lot of patients back, but if we don't get the brain back, there's not. I mean, all we have is a corpse. And what's that?
Organ donor.
Organ donor. Yeah, at a certain age, definitely. Is it under 70? I don't, man. Oh, crap.
I'm an organ donor, so nobody kill me to get my organs.
Hey, will you give me my bag right there, buddy?
You can take the liver, some of it, and you'll be okay.
Yeah. Just make sure I'm good to bed for you taken.
No, liver.
Oh, yeah, that's
It'll be
good.
fine. That always just freaks me out a little bit. I'm like, man, y'all better make sure I'm dead before y'all start taking my organs.
Well, I know whenever I first, very first got my license, they said, you want to be an organ donor? And I said, I don't know all about it. And there was a guy in there that I knew, he was organ donors, and then he says, well, here's the way you look at it. Do you want them to kill you just so they can have your organs, or do you want them to save you? And I was like, I want them to save me. So I wasn't ever an organ donor, and I was like, I don't remember if I got changed or not.
Oh, we're gonna try whether you're an organ donor or not.
They call. They don't have to, I know, they'll call.
FaceTime, I mean, yeah.
My mother is FaceTime with me.
She wanna join class?
She wants to probably talk to my kids.
So,
Organ donor people.
maintaining adequate oxygenation, avoid hyperventilation, and that's kind of that's where waveform capnography has changed how I ventilate my patients, but it should change how everybody ventilates their patient. You start breathing too fast, all of a sudden you get that end-tidal CO2 way down low. It's not really a good thing to do. So, performing 12-lead EKG, finding and managing treatable causes of arrest, your H's and T's. I don't know if they go over that in your book. Determining an appropriate destination for patient, possibly inducing hypothermia. It's kind of a new thing they're doing. We don't have a hypothermia protocol. The whole point of it is once you induce hypothermia, you have to keep them down to that temperature. I forget what the temp is, but all the way until they're brought back up. So if you can't keep them cold, you're not supposed to induce it. EMTs provide two links in the chain of survival: early CPR and rapid defibrillation. There's usually enough oxygen. Okay, we already talked about that. So, management of cardiac arrest: perform 1 and 2 rescue or CPR. Take standard precautions. Use an automated external defibrillator. Request ALS when available to continue the chain of survival. And use a bag valve mask device with oxygen. Use flow restricted oxygen powered ventilation devices. Lift and move patients, suction patient's airway, use airway adjunct, interview bystanders and family members. So the bystanders and family members a lot of times can give you a lot of good information if they're willing to give you that information. You know, sometimes you go to the local drug house or they've overdosed some heroin, they're not going to tell you that. And you have to figure that one out on your own usually. Usually they've left.
Yeah, they're by themselves with 10 people.
Yep, that's exactly.
Mm-hmm.
And them good old friends of theirs just left them.
Rich over. What are you doing? I said, I don't think he has a phone. Oh, he's got a phone. He's black, but he's only got some. But anyway, somebody can stop on me, but I'm reaching for addiction. Give me a moment. I'm not run with me. What do you want to do? I guess I'll pick my phone.
What the hell?
What is the other one? No.
I thought this was gonna be easy. It's going back to bed.
And then whenever you look around vacuum marks up to the body, I'm thinking, when you got up there, you're having a cardiac.
I guess. The types of AED, semi-automatic. You're going to see these almost everywhere. Advise the EMT to press button that causes machine to deliver shock through pads. To me, this is the safest type of device, and I've never actually come across a fully automatic AED, which does not advise the EMT to take any action, deliver shock automatically. So I do tell people, whenever you're using AEDs, listen to the voice prompt. If it tells you shocking patient in 3, or clear patient, shocking patient in 3, 2, 1, you better clear the patient because it's going to shock them. All right. Most of the AEDs now have an algorithm in them where they actually can sense your electrical activity and they'll cancel the shock. I'm not going to count on that though. Types of AED classified by types of shock delivered. Monophasic sends a single shock from negative pad to positive pad, so it's just one bolt across the chest. Biphasic sends a shock in one direction and then the other. So biphasic shock, and it uses less energy, is sending it both ways. And so whenever we're talking about monophasic, not that it's important to you guys, but typically we're up to 360 joules. Whenever we're talking about biphasic, depending on the manufacturer, you're stopping from anywhere from 100 joules to 200 joules. So you're doing about half as much electricity as a monophasic. What's that? The biphasic, yeah, definitely. Biphasic has been proven to work. Now they have all these weird things they're doing now, like dual synchronized dual sync defibrillation, where they're putting 2 monitors on them, and they'll go 3, 2, 1, and they do a shock shock. You can't shock them both at the same time, but they're doing shock shock, so they have 2 sets of pads. This is in Oklahoma City. Yeah, and until they make a machine that fires that like that, I'm not going to do it. I think that's ridiculous. And until AHA comes out and says that's what needs to be done. So how AEDs work: analyze cardiac rhythm to determine whether shock is indicated. If it is indicated, it's going to advise you that it's indicated, and it's going to tell you to press the red flashing button, or it's going to tell you that you're going to shock. Wow, I can't even read that. So moving on. Most common conditions resulting in cardiac arrest are shockable rhythms, ventricular fibrillation, ventricular tachycardia. Not that you need to know that, but whenever you're watching Grey's Anatomy and they have that flat line and they're like, shock, clear, and they shock it, we don't really shock that. Yeah, every time. You don't shock the flat line. What you do shock, typically, if it's a wide, bizarre, fast rhythm, but it's regular, it's ventricular tachycardia. If it doesn't look like any organized rhythm whatsoever, just a whole bunch of different size lines and jumbled all over your screen, they're either moving or they're in VFib. If they're in VFib, they won't have a pulse. Okay, so if they're moving around and it looks like that, don't shock them. You think they're in VFib, all right? So they won't have a pulse. Interrupt CPR only when absolutely necessary for a short period as possible. CPR must be paused for rhythm analysis and defibrillation. Perform primary assessment. If bystanders are doing CPR when you arrive, have them stop, verify pulselessness, apnea, absence of other signs of life no longer than 10 seconds. So, whenever you go in, hey, stop CPR for 1 second. Okay, I don't feel pulse. They're not breathing. I don't see any movement. Okay, continue CPR, or you're going to go ahead and take over at that point. So, you're going to check for at least 5 seconds, no more than 10. So patient care, you apply AD, bare patient's chest, quickly shave area where pads will be placed if necessary. And if available, use pediatric AED pads on pediatrics. If available, use pediatric AED pads.
Yeah, they're saying that you can use this if you don't really touch.
Well, are we doing, is this a pediatric? Okay, so pediatric note, if available, use pediatric AED pads. You can use adult pads on the pediatric, but you don't let them touch or overlap. You can do a front to back placement. So you just put one on the front of the chest, one on the back of the chest if you have to. Don't trim them down, but you cannot use the pediatric pads on the adult. It has a dose attenuator on it. It reduces how much electricity is used to defibrillate the pediatric patient, and it's not going to be enough, or it's probably not going to be enough to defibrillate the adult. You know, it's just weird how they put it right there in the middle of all that without saying, you know, a pediatric note like they usually do. So provide CPR while another EMT sets up the AD. Don't stop CPR while they're putting on the AD. Have them put the AD on around them. Today, I had Rodina stop simply to put down the pad that we compress on. After that, she continued compression. Use AED, turn on AED, attach pads to cables, and then to patient. Stop CPR and analyze. Clear patient and shock if indicated. Red flashing button. And it makes it yells at you and it flashes until you push it. Immediately begin CPR after delivering a shock. Reassess patient after providing 2 minutes or 5 cycles of CPR. You're gonna be doing compressions, and it's gonna come on. And it's gonna say analyzing patient. Don't touch patient after 2 minutes. At that point, you need to switch rescuers. After 2 minutes of compressions, you're too tired to do adequate compression. All right. So then you're gonna go through this whole 2 minutes. It's gonna say shock advised or no shock advised. If they're shock advised, you're gonna shock them. Go right back in your compressions for 2 minutes. After that 2 minutes, you're going to switch rescuers. Either shock advised or no shock advised. If there's no shock advised, check. Go ahead and check for pulse. If not, with no pulse, go ahead and do 2 minutes of CPR. Perform CPR for 2 minutes, 5 cycles, unless patient wakes up, moves, or begins to breathe. Follow AED prompts. If AED finds no shockable EKG rhythm, we'll advise that no shock is indicated. Pulseless electrical activity in asystole. So, in either one of these, it will tell you no shock is advised. Resume CPR immediately. When providing CPR, compressions must be not be interrupted for any longer than 10 seconds. Compressions at least 2 inches deep for adults and at least 1/3 depth of the chest for infants and child with full chest recoil. When providing CPR, rate should be at least 100 per minute. We've heard all these 100 to 120. Rotate personnel through compressor position to prevent fatigue. So every 2 minutes, you're going to rotate compressors. If patient wakes or begins to move, obtain baseline vital signs, administer high concentration oxygen, and transport. Be ready to do compressions again. All right. Do not take the AED off them. General principles, special consideration used for AED. One EMT operates as a defibrillator while others do CPR, or another does CPR. CPR must include high quality compression. Defibrillation comes first. You must be familiar with the model of AED used in your area. There's all kinds of different AEDs out here. All contact with patient must be avoided during rhythm analysis, so everybody has to go hands off. Pulse checks should not occur during rhythm analysis, so don't touch a patient. Stay clear and be sure everyone is clear of the patient before delivering every shot. Typically, what I do, I'm clear, you're clear, we're all clear, looking at the patient, make sure nobody's touching the patient before I shock. All right. Don't just hear it says shock and press the button, because there is a chance that somebody might be checking a pulse or maybe giving a ventilation. You want everybody clear from the patient. Check the batteries at the beginning of your shift and carry a spare. If you have delivered 3 shocks and are without a backup, prepare patient for transport. Wow. An AED is often not able to analyze a rhythm accurately in a moving emergency vehicle. So you may have to stop the vehicle to allow it to analyze. Yeah, you know what? If you do that, you're going to be stopping every 2 minutes. Go, stop. Go, stop. Like red light, green light.
But 2 minutes seems like how long impressions.
Forever. So coordinating with ALS personnel, notify as soon as possible to greater the patient's chance of survival. If the team arrives before you have finished the first shot, they should allow you to complete the shot. Your actions may depend on location of the arrest and estimated time of arrival of the ALS team. Coordination with others who defibrillate before you arrive. Let the operator, the AD, complete the shot before you take over care of the patient. You may need to take the first AED to the hospital with the patient so data can be retrieved from the machine. Your protocols will dictate transfer of care. So ours is pretty easy. So, if somebody else comes, they're going to take your patient. You typically, if their pads aren't compatible, we're going to take our pads off. They'll put theirs on. If patient has a pulse, manage airway. Avoid hyperventilation. Waveform capnography will save you. Keep defibrillator on patient during transport in case patient goes back into arrest. Reassess frequently, every 5 minutes. You guys know how I feel about that. And consider hypothermia protocol. Tyler, you ever taken vitals every 5 minutes? Yeah, me either. Yeah.
Not because I don't think about it, just because I don't have time.
Yeah, if you take it every 5 minutes,
You
it's
got
all.
if you're taking vital every 5 minutes, you got 4 or 5 people in the back of that truck.
Well, and that's all that's getting done is vital. So if a patient has no pulse, you'll need to resume CPR. AD will have given you a no shock indicated message. AD may be prompting you to analyze the rhythm because it thinks there is a shockable rhythm. What'd you do? Mess up my paperwork?
I'm gonna talk to you.
No, I'm
Weird.
No, I'm right. I'm right.
Better be.
I'm only seeing that one eye.
I will make you reorganize those. You don't realize how much time I spent building those packets for you guys. Ensure adequate ventilation and oxygenation. Adjust amount to no more than what is necessary to achieve oxygen saturation of 94%. Protocol may require you to place the patient in a therapeutic hypothermia. Use techniques of lifting and moving. Gosh dang, are they just going to the same thing over and over again? It's like slide after slide of the same crap. Patients who go back into cardiac arrest, stop the vehicle and resume CPR. Have someone else start CPR if the AD is not immediately ready. Analyze rhythm as soon as possible. Deliver shock if indicated. Continue with 2 shocks separated by 2 minutes or 5 seconds. Continue with 2 shocks. No, what you're going to do is you're going to do compressions. Whenever it's available, it's going to analyze patient. It's going to deliver shock, and then you're going to do compressions. All right? No, you're leaving them on, and you're not doing 2 shocks separated by 2 minutes. That makes no sense. Witness arrest in ambulance, no guarantees, but very good chance of reviving patient because you can defibrillate very shortly after patient goes into a shock rhythm. Saved lots and lots of patients, more in helicopter. I knock on wood, I have yet to have one in the ambulance that has gone there with me, that is arrested with me. I mean, they're arrested before I get there, or they're arrested as soon as I get to the hospital. But now, aircraft is a different story. I've had several that have arrested on me, and it is you get I would say that ups my my code save percentage a lot, because on a ground unit, I think I had 1 out of I don't know how many. It might be more than that because we had that old man that the lady was mad that we got him back, and then she let him die. That's still a code save. But it's very rare you get him back because of the distance that it is to us to get to. We get them back, but a lot of times they don't leave the hospital. They'll die in the hospital. They're brain dead or whatever. But whenever you're right there with them and they code, you're able to do all that right away. You get them back. Crap, we got to start these medications on them. So off the vehicle and treat this patient like any other patient in cardiac arrest. Apply the AED and defibrillate immediately once shock delivered or received no shock indicated. Begin chest compressions. After about 2 minutes, check rhythm again and shock as needed. Pads won't fit on patient without touching each other. So this is contraindications. If the pads won't fit on patient without touching each other, you don't want to touch them or overlapping. There has to be a space in between them. Trauma with severe blood loss or damage to one or more vital organs. In Sedgwick County, we had a blunt blue protocol. If they were dead because they were in a traumatic event, so like a car wreck or something like that, we didn't run it. We called it blunt blue. We called it. We didn't even attempt it. Now, if the damage to the car was very minimal and it looked like it was a cardiac arrest that caused the wreck, so they're driving along and they have a cardiac arrest, then we would run it. And then you don't want to shock a patient in hypothermia, so you get them warmed up. Do not defibrillate soaking wet patients. Dry them off with a towel. Do not defibrillate if patient is touching anything with metallic that other people are touching. This is electricity, folks. It can shock you. Remove nitroglycerin patches before defibrillating. Verbally and visually clear patient before defibrillating. There it is. I'm clear, you're clear, we're all clear. She's going to give him high five. The guy's dead. And he's like, what? No, you're crazy, lady. Anyway, so she didn't know what it looks like to you. She's like, give me a high five. He's like, not here. And no, she's going to shock. Implants and surgery. Defibrillation can be performed on patients with an implanted device. Position this defibrillation pad on patient's chest to avoid contact with the device. Not that you're going to blow it up or anything like that. You're just going to defer the shock from where you want it to go. So over to the side of the implanted device, we're typically talking about a pacemaker or a defibrillator, even sometimes some sort of access port. And so you don't want to place that pad right on those. Some devices and surgeries you may observe in the field include cardiac pacemaker, implanted defibrillator, ventricular assist devices, and cardiac bypass surgery. Quality improvement involves multiple functions: medical direction, initial training, maintenance of skills, case reviews, trend analysis, and strengthening the links of survival. How can we do our job better is what the whole QA process is. Or QA. Maintenance, use checklists to be, at the beginning of every shift to ensure you have all supplies and AED is functioning properly. This is where most of your old, worn-out medics throw the biggest fits and fight you the most. It's a breath of fresh air to get the people that come from like a little bit larger services that are used to checking ambulances every day, because they get in there and they check the ambulance every day, and they always find things every day. Tyler, how many? I bet what? Probably 3 out of 4 shifts you're either putting stuff on my desk that's expired, or he's putting stuff on the ambulance he's found is missing. And so,
and I mean, not always. A lot of times, especially with the drugs, it's something I know is one. I know it's going out. It's going out next month. Oh, we don't. I'll get it next month.
Yeah. But anyway, if you don't do a daily ambulance check and something's not on the ambulance, guess who that's on? It's not on your EMS director. Okay, that's what everybody likes to try to point the finger at me. It's my fault. I should be checking trucks all the time. Guys, I don't have time to check your trucks all the time. All right. It's not on the last crew. So if Tyler gets off, he was free and clear. It's not on his crew. It's on you. You're the one on that truck. You're the one running those calls. You're the one that needs to make sure all the equipment's there. And so that's something that I'm trying to start addressing with our people here. And we talked about you guys need to help start IVs. You know what the IV material is. You also need to check the IVs whenever you're checking trucks. All right. So let's say that you're like, why? But I don't start IVs. Well, let's say that you and another basic are on a run, and then all of a sudden Sabrina walks through your door because you're over at Hammond, and she goes out to get IV stuff, and none of it's there. Well, you just missed out on ALS assistance there because your truck wasn't fully stocked. you guys need to know, even if it's above your level, everything that's on that truck and check it. Not like I'm having a monthly meeting here and chewing you guys out. Make sure your battery is charged and you have a spare with defibrillator. No, I want to get these things started with you guys. 'Cause I think probably a lot of you will have something to do with my service, just kind of looking around. So, yeah, and that is one thing my people are really good about doing. I have a file cabinet drawer full of defibrillator checks because they check it every shift, and you need to, because what's going to happen if you don't check it that one shift, you forget or whatever.
One chance you do.
Yep.
Don't.
It's not going to fire. You're going to get they're going to sue you. They're going to get pull the records on that, and they're going to see that you didn't check the defibrillator that day.
One time.
One time, yep. So and that's a big deal. That is actually a big deal. Mechanical devices assist EMTs to provide high quality compression using the Lucas CPR device. Stop CPR just long enough to put the Lucas-based plate under the patient. Apply stabilization straps before moving the patient, and upon termination of arrest or return of spontaneous circulation, power down. This is something that I'm really considering. I want to write a grant for new monitors before I'm out of here, and so one of the things that I want to write for is new monitors and a Lucas CPR device. Because guys, if you're up in the bend of the river doing CPR, you and your partner are going to be wore out by the time you get to Roger Mills. It's just a lot of CPR. Lucas CPR device, you put it on, it does CPR for you. You just kick back and have a Coke and finish your sandwich. So, so you didn't miss lunch now. So. Using the auto pulse, align the patient on the auto pulse platform. Provide mass ventilations at a rate of 2 ventilations every 30 compressions. After 2 minutes of CPR, reassess for pulse and or shockable rhythm. Once you start resuscitation, you must continue until spontaneous circulation occurs. Then provide rescue breathing as needed. Spontaneous circulation and breathing occur. Another trained rescuer can take over for you. You turn care of a patient over to a person with a higher level of training. You are too exhausted to continue. You're by yourself. I always get this question. How about if I'm in the Grand Canyon and my hiking partner goes down? Okay, in all reality, you probably just go ahead and finish your hike without them because they're going to die. Might as well not waste your time. But if you want to sleep better at night, do compressions and do them until you can't do them anymore, until you know that you've done everything you can. You receive a no resuscitation order from a physician or other authority per local protocols, and that's what we did today. We called Dr. Krychek. We got an order not to transport the patient. We gave him the story of what was going on. He gave the order. We had a time of death. We go home. So it's and like I said, that's when the hard part comes. You got to tell the family, hey, I'm sorry, we've done everything we can. And the reality of it is, and a lot of people don't understand this, that if you have a paramedic on scene, we're going to do everything that's going to be done in that ER for the first probably 30, 40 minutes of that coach. Not until they get that patient back do we deviate from what they do. It's the same drugs, same stuff. And so whenever you don't get anything back, you're just delaying or you're tying yourself out. You're taking up resources. You're going to go to the hospital. You're going to incur a bigger bill. Not that bills should matter, but you've already done everything you can for this patient. What's that? You guys don't. Whenever you don't get them back, we'll start bringing them here.
No.
Roger Mills don't charge if we break them in. Yeah, I'm pretty sure we don't. Whenever we go run the code, even though those are expensive. That's an expensive little run. And I used an ET tube. I used a King. I used three things of Epi. I used $65 patches, $60 King Airway, $8 thing, probably $20 and $20 in Epi, $30 back valve mask. It's a, yeah, it's suction canister, young, diesel fuel, employees, expensive little thing, but it'll be something that we won't, if they're Medicare age, I think we bill Medicare, but I don't think, correct me if I'm wrong, you guys bill Medicare, but you won't send a bill to the patient.
Unless things have changed.
Yeah, I know, that's,
Gosh dang.
I-
The old days, 3
Ellen,
years ago.
yeah, Ellen and I could talk about, what, 3 years ago? Is that what you just said? Is that 2 years ago?
3 years ago.
We know what happened 2 years ago. What the hell happened?
Very good.
Back at clinical hours, if I jump out there on the helicopter, they'll be kicking me off. What the heck are you doing?
So-
Everybody run out there and watch.
Criteria to determine when it is reasonable to stop without missing anyone who has a what? Criteria to determine when it is reasonable to stop without missing anyone who has a chance of survival. Arrest not witnessed by EMS personnel or first responder. No return of spontaneous circulation after 3 rounds of CPR and rhythm checks with an AED. Criteria to determine. AED did not detect a shockable rhythm and did not deliver any shocks. They were on like, slide 100 and something. Let's see if this will play. I'll go back and play them. So you guys want to take a little break and go watch a helicopter land?
Yeah.
You can watch out my window right
See
there.
what's going on. Okay, outside.
Yeah, go get down. You watch.
That's all.
Take a.
Throw some rocks and beat my car some more in that, like that hailstorm the
I'm
other night.
glad I'm part of what it do. Oh, shit. We're gonna go right in front of me. Actually, I'm gonna do it.
I'm part.
Take a 10-minute break.
break. And
Oh,
it's not my vehicle, it's mine.
Oh, well,
you getting all that?
I think so. What's the hell the difference? Oh, that's the instructor.
Oh.
Hey, Rob.
Yeah.
Come here. What's this for? Is that this stuff?
Okay, so I didn't add the house. This is for you.
House. That's how the instructor.
This is the instructor.
So there's no test.
There should be a testing.
I didn't forget.
Was there not an answer key? And that's the instructor.
And that's the one that says.
Okay, there's. Oh yeah, okay. Yeah, there's no instructor. There's no instructor. There's no such instructor. And didn't add a test. The tests are for you to do.
That's this package.
Yeah. So those are for you to do. The reason I didn't do this is because the freaking pound pack is so thick.
Okay.
So no, keep those.
So that's that.
Okay, now
This is all you.
No,
I'm already
yeah.
signed it.
You already signed those?
Yeah, I signed it. Part of it. Right.
Kenny, Sarah, basically, a lot of stuff you're gonna put your name on, and I'm gonna check.
This right here,
I'm just gonna check it. So just put your name on.
there's work. There's no,
There's no place to put a name.
there's no this. So that's hers. This is me. So it's Sabrina.
Uh-huh.
And mine is that. I'm putting my name on that, but it's always.
Okay, just the ones that you put your name on, just do that. Don't worry about that.
And then this.
Yeah, they didn't, I'm not loving, they've updated everything with the palette, I think.
But,
So you still do any coaching? I think I start with Edward Jones January 1st,
okay,
and so I'm gonna do him shape like a CrossFit gym or something. I gotta do something.
so you are saying,
I think I got called Friday.
who's gonna replace you?
Maybe Brian Peters.
Really? If you could, I mean,
The only, okay, I'm gonna say, I thought of you, but I thought, I didn't think you'd want to. I thought you had other things on your plate that you're doing.
yeah.
If you want to, well, we're gonna open it up.
No. I think Brian's a good one, because I've had to, I knew, but I was told like October of 18.
Yeah.
So I was told this.
That was my initial.
And so I kind of kicked it around. Man, I don't like doing stuff in the office here.
Yeah.
And so,
I thought,
and then all the technical BS that I don't know.
and what we're gonna do is we're gonna take them on about, whenever I sign my contract, we're gonna go ahead and take the new director on and start transferring and teach them everything. People, there's a lot.
Oh, there's more. They don't have a huge happen
No,
behind it.
no, they don't. And
I don't have a clue, and I know what I do know, and it's more than,
I feel like I get frustrated with that attitude, when people say that about me or whatever.
Oh, I don't. I mean, how can I say that? I don't need your job for it. You know what I'm saying? It's a good job. It's needs to be done. There's so much to it. I don't know.
Whenever I first started it, I've only been there for 10 years, 8 years, by the time I'm done. I was busy about a month total a year. For the last 2 or 3 years, I haven't stopped. I haven't stopped with filling out paperwork, and getting forms done, satisfying the state requirements for stuff, getting trained to be able to train you guys, and then teach you guys all the classes. It just becomes so much more to it than just leading a team. I love leading a team. I don't love doing all that. And
Yeah, and that's why that's where I would do it too. Brian, he'd be good.
he's flaky.
Yeah.
So I kind of went through everybody, and I was going to tell you, and if you wanted, and you're already putting time, please apply for it. If it comes out something like that, I'm not going to. I'll step back. I'll let you guys, your guys' merit thing on its own. I think you.
No, I've got all this stuff. I did think like it is.
And then I thought, okay, but she's so committed to area that I don't think she would. And so I got Sabrina, but this isn't fast enough for Sabrina. Yeah, I just kind of went through everybody that I think that I want. Because I do want it to continue to be a type of place. And I don't know if you knew of us before I came, but it was kind of cool. I mean, it was good. I want for it to continue because it has turned into a place where a lot of really good people actually
Well, and I think they're going to do something next week. With what I understand, they're saying that person.
Yeah.
They're going to do it.
and that's that's kind of where we're at. She said he was at 55 at the level of I kind of built a service to attract that level of care. I can't afford to pay him, but all medics are for an easier side job, and I have a lot of people. And that, the part comes out, and I hope that, and one person can do what they want, but I hope they continue to improve the service. But, there's some things that I want to do to make it better. They're little things, but, I kind of, I think I kind of run my course with it, now it's the coaching, and I shouldn't say coaching, because the people think it's not going to be
Oh, and I don't do well at Facebook. I don't do well at that.
yeah, and don't do this because how I used to do the job, where I put this, is I would put in Hudson and Monday, and I'd work like you guys did, and I'd work Monday, and Tuesday, and then I'd get off sometimes Wednesday, and then, that's all I worked, I didn't work often, and so once the twins were born, I stopped doing it. And actually, at one time, I was flying full-time and here full-time. And so, I was able to do it, and then when the twins were born, I stopped doing that. Well, and then she came, she did a 50 foot, and I started working at shift, and she did it. Like,
It's colder in here. It's nice, it's nice.
but anyway, if you want, man, think about it.
That's amazing. I've looked at it.
But I'm gonna be looking for a gym.
Yeah.
And I enjoyed you coaching me the other day, so. I didn't know if you were still coaching or not.
No, I'm not still coaching. I need a good angry workout partner. I used to coach CrossFit. Oh yeah, where's that? Oh yeah, where's Jim?
The one that I'm moving to me.
Yeah, oh, yeah, she's your sister? She's Cross? Yeah. She's one of my coaches. Yeah, I sold that gym to, and she still coaches for us.
I just jealous that we don't have one.
Yeah, I've had people come for years. And they're like, it looks so fun. And I've had them come from even farther, but they work on the streets, and then we had showers, so they could get a shower.
So I'll ask you, Tyler, so that's after you, thanks.
What's that?
Where I got hit in the leg by that feet.
Like,
Still whining up.
Did I not say I got hit by a deer on my motorcycle?
yeah, so a deer T-bone you one more time.
Yeah.
Okay.
Well, it was I went one way. So here I am riding, and the deer comes out to the road. I hit my brakes and start to slide sideways. Deer turns around, so I let off the brakes. I aim for the back of it. The deer turns back around and then just runs right into me.
Okay.
Smack. And I see him turn around, so I throttled down to try to get by it.
Yeah.
And the deer and I hit and pretty hard. And about 5 miles later, my leg hurt. And like, wow, my leg hurts. I got home, I couldn't really walk all that well. I had a hobble. Next morning, I woke up and I was able to walk again. No limp or anything. And I have been. But now I have this freaking deep ache, like right here. Like if I touch it, like I rub it right now, and whenever I stop, it doesn't hurt. And then it'll start hurting, and it'll intensify, and it'll become like this deep ache, and it's still going right now. It's still increasing. Okay, now it's like a real bad headache right now. It hurts really bad.
How about you walk on?
If I walk on the fine.
Does it throb?
Mm-hmm.
Can you palpate it?
No, it doesn't. It's like a real deep ache, like a.
And you've had no energy?
Mm-mm.
Not anything, I don't know, but I mean, it could be any wrong. It could be. You need to start writing. Large, all kinds of scar tissue.
Muscle tear. What?
Let's just do chest x-ray.
Probably what I need. I said blood clot.
Well, yeah, that's a thought.
My wife says pulling muscle.
Yeah.
Eubank says he thinks it sounds like muscle.
Mhm.
And he's like, well, it could be either. But
Could be, you know, yeah.
it seems like it's getting worse than better.
That's what I thought.
Could be, big things on me.
But I-
Yeah.
when are we getting that?
Well, we talked to the board the other night, and they said, yeah, and she's like, okay, well, we're gonna look at them again and decide which one, and yeah, okay, and, 6 months or a year.
I need it in a week.
I'm like, you've already looked at them, you've already gotten in line, what, fit, well, somebody's gonna do it, some place,
And so then it goes back to normal. So it's headed back to normal now.
Yeah.
But when I sleep at night, if I lay in on, oh my god.
It could be the muscle stuff. Neurology.
Do that's what I'm talking to.
I know.
You don't have these tools.
I'm like, fix this,
Hands is nothing cool.
fix this, Tyler.
No, I can't even remember. Gets her out of the way.
My whole spine goes.
I had a horse chiropractor working in my house.
Chiropractor.
Would you do more animals or more people? This guy does more horse though. But I was like, man, can you talk like that? He did.
Yeah, he can have them.
They adjust horses?
I just want horses and
Oh,
dogs.
man, I've
Go.
been around horses all my life and I didn't know horses talk the way that they do. I was like, their withers talk? Are you kidding me? I was like,
The withers are easy to pop because it's 7-inch leather.
no, but I never even knew, I didn't know they talked. And I've been around horses all my life. I mean, I've never heard a horse snap, crackle, and pop like ours did.
I was just a bucking wolves, all kinds of stuff.
We did it, we did it, bucking bulls. But the only reason we did it is because, sorry. My kid's barrel horse popped the rib out. And so we had to get it put back in. Well, it kept popping out. We're like, okay, something's bad, we need to get it all fixed. I mean, all the way to the top of the head to everywhere. Which I knew their tail heads would pop and stuff, but,
So you can adjust your sternum with
oh yeah, I was in complete amazement.
a horse's sternum. It's pieces just like a vertebra.
So your horse had a fall day. Was it more pleasant after?
He was sore.
Or was he?
He was sore because he's probably been out of whack, just like a human. He was sore and then he got better, but we had to keep working on him because he had been out so long and we didn't know it. You put him back in, just like us, when you're out of whack and you get put back in, you're like, yeah, I'm kind of sore. But I got bucked off,
Okay, that is your packet to keep the rest of it.
I got bucked off
we-
about 2 weeks before that, and my hip, the way I hit the ground, it jarred my hips. One leg was shorter than the other.
Just remember, we need to sign up for the AHA Instructor Network. You want to do it on your own, just Google AHA Instructor Network.
Yeah, I'll do it next year.
Yeah, that's fine.
I'll swing by next year.
All right,
You
man.
guys,
Chapter review. Patients with cardiac compromise or ACS can have many different presentations. Some complain of pressure or pain in the chest with difficulty breathing. Others may have just mild discomfort that they ignore or that goes away and returns. Between 10 and 20% of heart attack patients have no chest discomfort. Oh, is that getting in was that annoying?
See you. I like to see you.
Because of the possibilities and the severe complications of heart problems, it is important to have a high suspicion and treat patients with these symptoms for ACS. The treatment will not hurt them and may help them. Right? Something that's always been said is err in favor of the patient. So if it's okay to overtreat them, you don't want to undertreat them, right? The patients with suspected ACS who are hypoxic or short of breath need oxygen and prompt, safe transportation to definitive care. You may be able to assist patients who have their own nitroglycerin in taking it, thereby relieving pain and anxiety. To provide a maximum chance of survival for patients in cardiac arrest, EMS agencies must strengthen their performance of the chain of survival. Immediate recognition, guys, and I think you'll need to know the chain survival for probably your test and for National Registry. Immediate recognition and activation, early CPR, rapid defibrillation, effective ALS, and integrated post-cardiac arrest care. They'll give you something like induced hypothermia falls under which chain of survival for American Heart Association, which would be integrated post-cardiac arrest care, right? Defibrillation falls under which step? Rapid defibrillation, obviously. So that's how the questions will be. Is that kind of how they were on the chapter test?
And they did ask. What was the most important step for the EMT?
Oh, okay. So what was the most important step for the EMTs, which is early defibrillation, right? So it's early CPR and early defibrillation are the most important things. The heart is a simple pump. Simple. Heart's one of the coolest organs in the body. It has all these properties. It could beat on its own outside of the chest. It doesn't even need the chest. It does need a rich supply of oxygen. It has automaticity, so it's chronotropic, so it has its rhythm. It's a really cool organ. I don't really think it's simple though. The heart it's not as complicated as the brain. The heart is a simple pump that moves deoxygenated blood to the lungs and oxygenated blood to the body. Pressures within the cardiovascular system is critical to moving of blood. Acute coronary syndrome, ACS, is a blanket term that refers to a number of situations in which perfusion of the heart is inadequate. Although there are common symptoms of ACS, EMTs must recognize atypical findings and err on the side of caution. That little old lady that just doesn't feel right, or I just don't feel good. I feel like something bad's going to happen. Impending doom. The sinkhole episode, no history of sinkhole episode. All of a sudden they have a sinkhole episode, which is passing out. You guys need to err in the favor and look into cardiac. You don't want to get to the hospital and they're like, oh gosh, they're having an MI. Only if somebody would have done something for them 3 minutes ago. I don't know if it's ever that bad. But, oxygen, nitroglycerin, and aspirin are key medications indicated to treat ACS. However, the definitive treatment is transportation of the patient to a facility that can open the blocked artery. We have kinase, which will reperfuse the heart until they can get to a cath lab. I believe Elk City does. I wish that Elk City would have an interventional cath, but that requires having a cardiothoracic surgeon and all kinds of things that they don't have. But it'd be nice because I think they could catch a lot of people that wouldn't need to go to the city. I mean, we're probably talking all the way to Weatherford, all the way, maybe even into Texas, maybe to like Shamrock-ish. All the way, if they did an interventional cath, they could get a lot of patients. But they don't. But these hospitals do have medications that can get them reperfused, and they can get them on a helicopter. You could always weigh the odds. A lot of people feel a lot more comfortable if AirEvac comes and takes that patient off their hands. AirEvac can get them to a cath lab fairly quick. Did that helicopter ever land? Sure.
It was right over here and it was coming and then it disappeared. I never saw it again.
I think they canceled it. Was it AirEvac? Huh.
It was right over here by these telephone wires right behind these trees. And it was coming. It's gone.
Crash out in the field.
Landed on someone's house. I don't know.
I've landed in a neighborhood before. That was really weird. Yeah. Not I was right in the back. But, muscular conditions are caused by atrial problems. Angina pectoris and acute myocardial infarction are caused by inadequate perfusion of the heart. What was that? Heart failure can be caused by either electrical or mechanical problems. The most important element of cardiac arrest care is the administration of high-quality chest compressions. American Heart Association Chain of Survival describes the key elements necessary to maximize the cardiac arrest patient's chance of survival. AED provides early defibrillation to cardiac arrest patients with ventricular tachycardia and ventricular fibrillation. Post-cardiac arrest care is an essential element of cardiac arrest care. Mechanical CPR devices provide automated chest compressions in cardiac arrest settings. And it doesn't tire out. It's about to go dead. What position is best for a patient with difficulty breathing and a blood pressure of 100/70? Yeah, probably. I'd probably think about chest pain and blood pressure of 180/90. Definitely sit that. The difficulty breathing and the blood pressure of 100/70. If they're, let them sit in a position of comfort. But most likely with the difficulty breathing, they are going to want to sit up. Describe how to clear a patient before administering a shot.
Get their head. Look.
What the hell are you doing?
Oh, you got shot.
I'm clear, you're clear, we're all clear.
How's your heart? How's your heart?
So list 3 safety measures to keep in mind when using an AED. 3 safety measures.
Everybody go clear.
No, dry them off.
Yeah, dry them off, don't touch them, and stay clear.
No touching metal on the pads, not touching.
I'm not going to have you guys list it. So, a 78-year-old man has been complaining of severe shortness of breath for 20 minutes prior to your arrival. When you arrive, you find the patient unconscious and not moving. What are your immediate priorities?
Pulse and airway.
Yeah, you want to if you go through your thing, gloves on, scene safe, blah blah blah.
Tell them how well I did. Yesterday.
Oh, you did awesome. She did gloves on, scene safe, and the hospice nurse says, "Oh, he's dead."
So this was our question. Why did the hospice nurse call y'all?
We don't. I was wondering that myself because whenever we got there, I didn't realize it was hospice. I just thought it was a home health nurse, which so there's a big difference between hospice and home health. And so she's like, "Oh, he's dead." And I was like, "Well, what do you mean by he's dead? How long has he been down?" I don't know. I just got here and he's dead. Is he still warm? I don't know. Does he have rigor? Rigor? He said, "Did he have dependent lividity?" I don't even know what that is. Do you mind if I go look at the patient? I don't know why it really matters. He has hospice, and I'm his hospice nurse. That's all you had to say is hospice. You didn't say, "Hi, I'm his hospice nurse," and you know, she's just like acting like, you know, I was stupid.
Basically, sounds like she doesn't want to know.
Well, you know, it's like sometimes people are like, "Oh, they're dead." What do you mean they're? No, they're not. Not in my world. They're not dead. We could try to fix this. And so that's where I was going with it. But she's like, then when she said hospice, like, well, I'm his hospice nurse, and it pretty much revokes anything you're gonna, you know, like, your hospice. I didn't know. That explains everything. Thank you. Have a nice day. Look at that. I would talk to the sheriff's department. But anyway, 70-year-old man has been okay. So yeah, so we go through our checklist here. Gloves on, scene safe. We get there, obviously the scene is safe, right? And so our priorities are assessing airway, breathing, and circulation at this point. All right. I'm going to go back to the very beginning and play those videos. Okay. This one's good. Maybe not. Right this way. Freddie's gonna take me to that slide. Oh, it doesn't want to play tonight. Let me see if they're in the folder.
Cardiac arrest, the cessation of the forward movement of blood from the heart, can occur when massive myocardial infarction results in dead myocardium, which is unable to contract despite continued firing of the SA node. In addition, dysrhythmia, such as ventricular fibrillation, can result in inadequate stroke volume and the cessation of forward movement of blood from the heart.
How do you get to the next one? Oh, okay. I got it.
The use of automated emergency defibrillators, or AEDs, as life-saving devices is becoming more and more common. An AED sends an electrical current through the myocardium of the heart, briefly causing the heart to stop and allowing the heart's natural pacemaker to take over. The AED is brought by a second or third party rescuer after the initial chest compressions and rescue breathing have begun. Place the AED next to the victim's left ear. This position allows the rescuers clear access to the chest and airway for continued rescue measures. Turn the AED on and follow the voice prompts. Prompted to attach the electrode pads to the patient's chest, on the sternum, and at the apex of the heart. Follow the diagram for correct placement. The machine will analyze the heart rhythm to determine if it is a shockable rhythm. CPR should cease while the machine is analyzing. The machine will charge and warn rescuers to stand back. The voice prompt will then tell you to press the shock button to administer the electrical current. If the machine indicates no shock is advised, assess the patient for breathing and circulation. Continue CPR as needed until advanced medical personnel arrive. A healthy heart pumps regularly at various levels of exertion and coinciding heart rates. Cardiac arrest occurs when the heart stops pumping correctly. Chaotic electrical activity throughout the heart causes uncontrollable fluttering or ventricular fibrillation.
There you go.
The heart beats
Does that help
erratically,
make sense
no
how
longer
the
pumping
conduction
oxygen-rich
system
blood around the body, which starts to shut down. Automated external defibrillators are designed to shock the heart back into its normal rhythm. Placing two monitoring
call it a bag
electrodes
of
on the
worms.
chest, the AED measures the electrical activity of the heart, analyzes the cardiac rhythm, and determines whether a shock should be administered.
That kind of help you with how the
It
conduct.
doesn't work with that one though, does it?
Yeah,
It does help with that one?
yeah. Ventricular fibrillation, ventricular tachycardia. Ventricular fibrillation is described as a bag of worms. You see the heart; it kind of looks like a bag of worms. It's chaotic. Yeah, what you want to do, what the whole point of the AD is to stop that. Those pacemaker cells where the one that electric current just went down in a rhythm takes back over. Right? As that shock or that pulse goes down the electrical pathway, the contraction of the muscle falls. That's where you get the squeezing effect. That's why it shut it from the down and down. Whenever you have the bag worms or ventricular fibrillation, it's pulses are coming from all over, and there's no rhythmic squeezing of the heart. It's just a quiver, and that's not an effective pump. And so what you want to do with an AED is you're shocking that to stop it. You send multiple electricity through it to kind of override all the electrical pulses, hopefully stop them, so then they start back up here at the SA node, the patient, and kind of gets back into that rhythm. It's actually, to me, is a good diagram.
Coronary heart disease, CHD,
Also referred to as coronary artery disease, CAD, is the most common type of heart disease.
Coronary artery disease is a plaque buildup within the arterial wall that can start from anywhere from birth if it's a hereditary problem, or it can go with the aging process, depending on how many risk factors that individual has not done necessarily correctly. The big three are hypertension, which is high blood pressure, smoking, and high cholesterol. If you think about the heart as a pump, because that's literally what it does, and the blood vessels are the pipes that the pump has to pump to, if the pipes narrow over time, and the aging process, with the aging process, we start out this world with elastic blood vessels, and they become more firm, like a pipe, as the person ages. You can prematurely create that elasticity loss to a pipe-like problem with atherosclerotic vascular disease. So if you can think of the concept of a tube this big and a tube this big, it is much harder for the blood to get through a smaller tube, especially one that's not elastic and cannot adapt to the increased flow that you need.
CHD is a progressive disease increasing the risk of myocardial infarction, heart attack, and sudden death. Symptoms vary, but include angina or chest pain, shortness of breath, and may be accompanied by swollen feet and ankles. Coronary heart disease is the leading cause of death in the United States. About every 29 seconds, someone suffers from a CHD-related event.
All right. So that's 18, right? What is 19? When are we supposed to get through 19? We're supposed to get through Thursday? Yeah, let's go ahead and start it. You guys want to watch the videos first?
I don't get to watch videos online.
Diabetes mellitus is a complex disorder of metabolism. It is a disease in which the body does not produce or properly use insulin. Insulin is a hormone that is needed to convert sugar, starches, and other food into energy needed for daily life. There are three major types of diabetes. Type 1 diabetes, also known as insulin-dependent diabetes mellitus, IDDM, or juvenile onset diabetes, results from the body's failure to produce insulin. An individual with type 1 diabetes needs to take daily insulin injections for the rest of their lives. It is estimated that 850,000 to 1.5 million Americans have type 1 diabetes. Non-insulin dependent diabetes mellitus, or adult onset diabetes, results from insulin resistance combined with relative insulin deficiency. Approximately 16 million Americans have type 2 diabetes. Someone with type 2 diabetes may make healthy or even high levels of insulin, but obesity makes the body resistant to its effect. Even modest lifestyle changes, such as eating a healthy diet, exercising 30 minutes a day, and maintaining proper body weight for age and body type, can help prevent type 2 diabetes. Prediabetes occurs when a person's blood glucose levels are higher than normal, but not high enough for a diagnosis of type 2 diabetes. Without lifestyle changes, most people who have prediabetes will progress to type 2 diabetes within 10 years. Gestational diabetes, or pregnancy-induced diabetes, develops in a pregnant woman. In most cases, this type of diabetes goes away after the child is born. It affects about 4% of all pregnant women, or about 135,000 cases in the United States each year. The American Diabetes Association estimates that about 17 million people in the United States have diabetes, and 5.9 million Americans have diabetes and do not know it.
Oh, really? But if you
Transient ischemic attacks are temporary and short-lived cerebral ischemic episodes that may be caused by a variety of factors. Here we see the cerebral vascular supply showing the carotid and vertebral arteries and the circle of Willis. In stenosis of the vertebral or carotid arteries, the reduced blood flow is insufficient to maintain adequate cerebral perfusion, and transient focal ischemia occurs. Other causes include subadventitial arterial dissection, which creates a false lumen that can cause stenosis, occlusion, or pseudoaneurysm of the vessel. The dissection may also cause the formation of a thrombus from which fragments embolize. Arteritis or inflammatory vasculitis may cause segmental stenosis and distal ischemia.
what? Should pay attention, I guess. Holy smokes, 105 points. You guys look excited tonight. Where's Amber at tonight? Oh, okay. Did you tell me about that? She did? Okay.
Come on, now, let me touch today.
I'm too tired today.
Oh. You guys are terrible.
I lost days.
Do what? Oh no. Let's get through maybe like the first little section of it. We'll reevaluate at 8:30, so 10 more minutes. I want to get into it somewhat. So, topics: pathophysiology, assessing the patient with altered mental status, diabetes, and other causes of altered mental status. Pathophysiology. Normal consciousness is regulated by a series of neurological circuits in the brain that comprise reticular activating system, or the RAS. The RAS is responsible for functions of staying awake, paying attention, and sleeping. So you guys need a little kick in the RAS. The RAS keeps a person alert and oriented. Requirements for the brain tissue of the RAS to function: oxygen to perform, oxygen to perfuse brain tissue. I need some. Glucose to nourish brain tissue. Water to keep brain tissue hydrated. Ellen says it's very important. Now you must have to already do some testing here. Overachiever. That's good. That's what I wanted to do is have it done before the class starts. Good job, Ellen.
It's not here till Thursday.
Yeah, this is a Thursday class.
I do that class. Midnight.
Pathophysiology: causes of altered mental status: deficiencies in oxygen, glucose, and water to the brain; trauma, infection, chemical toxins harming brain tissue; primary brain problem is stroke; problem with another system, hypoxia due to asthma. Assessing a patient with altered mental status. Patient with altered mental status can be dangerous to responders. Like I'm sure Ellen could attest, your patients that are the diabetic patients with blood sugar low, sometimes they'll fight with you. Just like I've told you guys about the people that you bring out from narcotics, and the people who are, I can't think now, post-ictal, after seizure. They've all, their mental status has changed, and they could be dangerous if you try to approach them. Yeah, and you invade their space, and they're just trying to defend themselves. One of the strongest people that you'll ever encounter are your head injuries. They fight harder than anybody else you'll ever encounter, and that's usually how you know that it is a true head injury, is because of how hard they're fighting. Always consider safety of yourself and your team before approaching a patient. Use law enforcement when necessary to help you with these patients. Loss of consciousness with syncope is usually brief. The patient usually regains consciousness very soon after being allowed to lie flat. Hypoxia is one of the most common causes of altered mental status. Always consider the possibility of an airway and or breathing problem. Identify and treat life-threatening. Kicking the Raz. Identify and treat life-threatening problems. Consider oxygen administration. Be alert to the need for positioning and suctioning if the patient requires it, or if mental status worsens. Determine baseline mental status for patient. Get all worked up thinking you're getting ready to fight, and then mom tells you that no, this is his normal mental status. Oh, okay. Thoroughly examine patient exhibiting new, unusual behavior, and even slightly altered mental status indicates serious underlying issues. Okay. Perform a primary assessment to determine if the patient's mental status is altered. A lot of times we'll do this with a, hi, how you doing today? I'm doing fine. Or they say, screw you. And then, this is a silly question, but you know what year it is. It's 1963. Get out of my house. You know that there's a problem. Do what?
I said, I used to get asked the dumbest damn questions, whenever I go in, whenever I have my dad and my kids, is homework working? You ask me idiotic questions.
They're
I really wanted to bet on.
They're assessing you. So,
I get that, but it's like really, if you're asking me this idiotic question at the same time, I don't even have a fair to answer you.
well, you better find it. I need an answer. Will we make a mistake?
There's your piece.
So, body systems exam and complete history may reveal information about the suspected cause of altered mental status. Interview family members and bystanders to obtain patient's baseline mental status. Family may provide information patient is unable to give. We kind of talked about utilizing. Well, this is, I would say this is a side effect of after you run a call it, you get an adrenaline rush, and you come off of it, you start yawning. But I was yawning, I think last class too. Eating a Reuben and cheese fries. Secondary assessment. Patients' medications may point to relevant medical history. So, let's say like your type 2, you find some medications for type 2 diabetes, might let you know that why they are acting erratic. Look for medic alert bracelets or other health-related items at scene. Answer questions in the same manner as adults, and therefore mental status is often difficult to establish. Ask parents or caregivers, are they acting differently than normal? In children, you learn a lot from walking in and just watch them. Are they acting normal for a child their age? If they're not even paying attention to you, they're not moving, they're lethargic, there's something wrong with that kid. If they're crying whenever you go try to take them from mom, and they don't want to go, don't want you to touch them, that's pretty normal for a kid, right? So, What kind of information about a patient's altered mental status might you obtain from the scene? And how might bystanders help you identify the cause of altered mental status? What kind of information about a patient's altered mental status might you obtain from the scene? Things such as medications can help you out. If you get a history from bystanders, that could help you out. Bystanders being family members typically. Diabetes. So glucose in the digestive system. Glucose, form of sugar, body's basic source of energy. Body cells require glucose to remain alive and create energy. So kind of I think I told you guys about the Krebs citric acid cycle. You need glucose and oxygen to create more energy. So glucose molecules are large. Glucose molecule is large. Will not pass into cell without insulin. I drew you guys a little elevator with the hotel and the gatekeeper or the keykeeper being insulin. You did. So basically, I drew a very simple way to look at glucose and insulin in the body is to think of the cells as a motel, all right? And then with a gatekeeper or a keykeeper, a bellboy or whatever, with the key to the room, that's insulin. You as a guest is the glucose. You need to get into the cell or into the hotel room. You need that gatekeeper, the bellboy, to open the door or unlock the door for you so you can go in. And so you have to have insulin to get the glucose into the cell. Yeah. Glucose in the digestive system. Insulin is needed to help the cells take in glucose. Oh my God. Insulin in the pancreas. Insulin is produced by the pancreas, binds to receptors, sites on cells, allows large glucose molecules to pass into cells. Sugar intake, insulin production balance allows body to use glucose effectively as an energy source. You run into a problem whenever you don't produce enough insulin to handle all the sugar. You end up with a high blood glucose, right? So you don't have enough insulin, you have all the sugar floating around, you get it out, it's in your blood. It's very necrotic to your tissues. It can alter your LOC if it gets high enough. What's the other saying? Mad as a hatter, right? They could get kind of flush red. They aren't real joyful to deal with. I've seen them as bad as they've had sores that have gone all the way to the bone on their fingers and toes, knees. That rotten foot, that's a complication of not taking care of your diabetes.
The rotten foot, everyone has one been in the boot forever.
Yeah. Who did? Oh, they're showing it too.
They're like, did you say the rotten foot? And I was like, what's the one that's rotten at? That's a diabetic guy that has his foot in the boot for a month.
Yeah. Yeah, I would say it's probably more than a month. That's just.
Oh, that's what they were saying.
And so then on the inverse side, you have too much insulin and not enough sugar, and you go into insulin shock, so your blood sugar goes way down. That's not good.
My sugar.
So here's two types. Type 1, pancreatic cells do not function properly. Insulin not secreted normally. Not enough insulin to transfer circulating glucose into cells. Synthetic insulin typically prescribed to supplement inadequate natural insulin. Okay? Type 1 diabetics have to take insulin. You know they've become a really bad type 2 diabetic whenever they are on insulin as well. Type 2 diabetes, body cell fail to utilize insulin properly. Pancreas is secreting enough insulin, but body is unable to use it to move glucose into cells. Condition often controlled through diet and or oral anti-diabetic medications. Jacqueline always, when she talked about it, always talked about it as becoming kind of almost like your body becomes numb to that sugar, so insulin really doesn't work anymore. So, you have two types. You have juvenile onset and adult onset. Typically, type 2 is adult onset. Type 1 is juvenile. So hypoglycemia, low blood sugar causes diabetic takes too much insulin. Diabetic does not eat. Diabetic overexercises or overexerts. It doesn't put in enough calories. Diabetic vomits. Diabetic increases metabolic rate through fever or shivering. Hypoglycemia signs. Very rapid onset. May present with abnormal behavior mimicking drunken stupor. Pale, sweaty skin, tachycardia, rapid breathing, seizures. Got called to Turnpike in Topeka. And an officer has this guy out of his car. The guy had gone up the wrong way on the on-ramp. And the officer knew that he was drunk. And so they call us to go there because there's all these stories about them throwing these guys into drunk, taking them dying because their blood sugar's low. And so anyway, they bring us in over there and they say, do you think his sugar's low? I said, no, I'm supposed to get him the ambulance and check it out. And he's like, I'm a lawyer. All I need is some coke. And so me thinking lawyers and the white powdery stuff, cocaine, I was like, man, no, cops right there. Like, no, coke, the drink. I was like, oh, okay, I'll go check your blood sugar first. Yeah, I was so embarrassed because I really was thinking stuff about you just need some coke. And so anyway, I checked his blood sugar and it's freaking 20. And so yeah. So I said, I told Al, I was like, yeah, his blood sugar's way low. It's 20. Yeah. No, exactly. It was amazing.
But mine's done that before. Gone that low. Because I drove myself from here. I had a Dr. Pepper and a package of powdered donuts. Drove upstairs to the health department and they checked it and it didn't even register.
You said low?
And they said, are you still kidding? Yeah. Like, you drive down there? Yeah. Do you eat it? Yeah. So like, you're sitting in the business. Walking.
Yeah. So anyway, that's a bad deal.
And how do you fix it?
What do you mean how you fix it?
You don't.
No, I give you an IV and give you extra.
Well, that's what I'm saying. Because in the morning time, when I first get up in the morning, I eat. Yeah, I don't have time. I eat. It's the only time that I eat sugar. Like
I mean, there's don't have to have always sugar. Your body will convert things like a carbohydrate, like bread.
I eat, but I carry like people are like, why do you carry food in your car? I'm like, you never know, like peanut butter crackers or.
Yeah, I mean, peanut butter has sugar in it, but also there's like you have the complex carbohydrate. The body breaks it down into slower. It's a slower form of sugar. It's a slower form of sugar. Result: starvation of brain. So hypoglycemia, starvation of brain cells. Your brain loves sugar, loves it. That's what it works on. Altered mental status, unconsciousness, and permanent brain damage. That's what's wrong with sugar. So hyperglycemia, high blood sugar, causes decrease in insulin, may be due to body's inability to produce insulin, may exist because insulin injections not given in sufficient quantity, causes stress, increasing dietary intake, signs, develops over days or weeks, chronic thirst and hunger, increased urination and nausea. Results: profound dehydration, excessive waste production released into the system, and then they have diabetic ketoacidosis. Some people can smell ketones on people's breath, and they say it smells like juicy fruit. I am not one that can smell a ketone. Not everybody can smell it. I've had patients with blood sugars up into the 1,000, and lots in the 600s, and I have never, ever smelled the ketone. You don't? What do you think they smell like? I can't. I guess I can't smell it. I don't smell it. People are like, "Oh, I smell ketones." I'm like, yeah, I don't smell anything. I can't. Diabetic ketoacidosis, profoundly altered mental status, shock caused by dehydration, rapid breathing, acetone odor on breath. You get acetone more of a insured scene, safe scene, perform primary assessment, identify altered mental status. So when Dustin first became a paramedic, people kind of made fun of him for working at such a small service. Gave him crap. That's what they like to do when you're a busy service. But Dustin has been able to run so many calls out here that you just don't see. Dustin had a guy that was in septic shock with a blood sugar of 1,200. He got saving him initially. What's that? I believe I think he actually went home and died later. But a blood sugar of 1,200 is something that I've run lots and lots of calls, and I've only had a couple. No, yeah, you have to get it from the lab. You have to get that reading. I think the commoners get about 600, and then they just read high. When they read high, you're like, uh-oh. And so anyway, it's just funny because of the things that Dustin, his first year or two had here, 3rd-degree heart block. You just don't see a lot of them in the field, and all these really cool calls and medical calls and stuff, really bad traumas that you just really don't get. And the guy that makes fun of running nursing home calls. So it's kind of a cool little service because it does have a lot of actually critical patients. Perform secondary assessment, history of present episode, for time of onset, duration, associated symptoms, any mechanism of injury, or other evidence of trauma, any interruptions to episode, seizure, or fever. Whatever. Perform secondary assessment. So you do want to do a sample history. You guys need to get down your sample history. I might do a pop quiz on sample and OPCRC history and see how you guys do. Might. Wouldn't be a pop quiz then, would it? Might do. Might happen. I did a pop quiz on the bones once. That's fun. So, determine history of diabetes. Question patient or bystander. Look for medical identification bracelets. Look in refrigerator or elsewhere at scene for medications such as insulin. And then perform blood glucose monitoring if local protocol permits you to do so. Your local protocol permits you to do so. Well, that is one thing that this service is really good about. I complain about them a lot. I praise them a lot. But one of the things they're really good at is checking blood sugar. They check a blood sugar on everybody. That's cool. They're good at it. Yeah. And was he having an altered mental status at all? No, but they checked his blood sugar, right? It's something that they know they could do. They do it. So you know what? They don't get surprised by that patient that has a slight altered mental status. Yeah. So she's not going to get surprised by that patient that you can't quite put your thumb on what's wrong, and then you get in the hospital to have a blood sugar of 30. That happens. You're like, I just can't figure this out. What's going on with them? I don't quite get it. And you don't check their blood sugar because they're not confused or anything. Maybe they're not even diabetic. You don't even check their blood sugar. You get them to the hospital, and they do their routine blood, and they're like, oh, blood sugar's 30. And like, yeah, that's not going to happen if somebody checks their blood sugar all the time. So, blood glucose meters, measure amount of glucose in bloodstream, often used by patients at home, sometimes used by EMTs, for example. Here in Oklahoma, all the way down to first responders could check. Use your machine, don't use a patient's. That way he looks like he's off in a bad way. The blood glucose measurement less than 60 milligrams per deciliter in symptomatic diabetics. Hypoglycemia, less than 50 milligrams per deciliter. Significant alterations in mental status. I believe, is it 80 is considered normal, and then down to 80, and you go down to 60 before you really start to get concerned about it. Oh, so that, they want it under 100 now. So blood glucose measure greater than 140 milligrams per deciliter is hyperglycemia. Greater than 300 milligrams per deciliter for prolonged time, dehydration, other more serious symptoms. So you start running into other things, and you'll start running into that where it starts to eat the skin, create the sores. And a lot of these people would rather buy their cigarettes and their booze than to get the insulin, and so that just exacerbates the problem. And then they call us whenever you see their bones, and that's all kinds of things. It's that. Yeah, and used to they had to have Medicare Part D or the DME side of things, and I think now a lot of insurance companies are allowing them to go ahead and get them at their pharmacy too, as long as it's a certain need and stuff. Yeah, that's one thing that definitely, yeah. I wish I'd take more of that thing. Special glucometer readings may display words instead of numbers. High or high indicates extremely high level, usually greater than 500 milligrams per deciliter. Low indicates extremely low levels, often less than 15 milligrams per deciliter. So whenever you get that low or that high, you know that you got a problem. There's a glucometer. Patient care. Occasionally, one can treat a person with mild hypoglycemia and minor altered mental status by simply giving something to eat. For us, the fastest way is oral glucose, rather than have to wait for them to convert the sandwich. A lot of times you'll get there and they'll give them like orange juice or something like that. If they have, go ahead and let that give it a little time to work.
One of those stimulation and when you give the juice and that. They were, they didn't do the thing, I missed this, and I missed the rejection. And I'm going, what do you want to do? Them on the fridge and juice and
Heck yeah, give them a sandwich.
I don't want that.
What, sir, I'm going to go get you a sandwich. The thing is, I got to also have, I'm hungry. I'm hangry. Yeah.
I can't think to help you. I need to eat.
Be aware of what family members give them. Like if they said we gave them something to drink, look at what it is, because sometimes they will give them a diet soda. All right, that doesn't do anything for blood sugar. Okay, they just don't understand it. It's okay. Well, that's great. Well, yeah, exactly. It's a pop, but not Diet Dr. Pepper. So either give them more glucose or say, hey, do you have some orange juice or something to give? Don't make them feel like an idiot. Say, idiot, that's diet pop that has no sugar in it. But you can use it as a teaching moment. Be nice to them. Say, oh, do you have something else? Because this is a diet soda and it doesn't really have any sugar, so it's not going to help them out. So that they don't do it again. So. Never administer food or liquids to a patient at risk for aspiration. I told you guys, say you can't protect the airway, don't put it in their mouth. Oral glucose, criteria for administration, history of diabetes, altered mental status, awake enough to swallow. So they have to be able to protect that airway. Even though they have an altered level of consciousness, they have to be able to swallow. A patient squeezes glucose from tube directly into the mouth, and I promise you, you're going to be squeezing it into their mouth, okay? Most of them, yeah, or they're just, they don't, I don't know. EMTs can administer glucose using tongue pressure. It's easy to deal with the unresponsive diabetic patient than it is the altered level of consciousness. Okay, so you can use it using a tongue depressor if they can protect their airway, if they can swallow, okay? That lady right there, she just, she's all chill. Oral glucose, reassess after administration. If condition does not improve, consult medical direction about whether to administer more. I would be en route to the hospital at this point in time. They might be doing something else. Hypoglycemia and hyperglycemia compared. Onset, hyperglycemia has a slow onset, while hypoglycemia tends to come on suddenly. Skin, hyperglycemia patients often have warm, red, dry skin, while hypoglycemic patients have cold, clammy skin. Breath. The hyperglycemic patient typically has an acetone breath, but not all patients exhibit this sign. There is HHNK, hyper, I don't know, something like hyperosmotic, I forget these things. So diabetes etiology and pathos. We already watched the video, right? Yes. Okay. We will come back to other causes of altered mental status on Thursday. 13, remember that, okay? Do you guys have any questions out there in TV land? And remember, next Tuesday is CPR lab, right?
Yeah, it's Tuesday.
All right. If you guys don't have any questions, I'll talk to you Thursday.
Alrighty.
All right. Bye.